evening, everybody, and welcome to today's episode of Marvelous Medicine. And the title is COVID, Time to Sing the Requiem. The speaker is Dr. Balasubramanian. He's the head of the Department Infectious Diseases, HIV, and Tropical Medicine at Apollo Hospitals, Chennai, and adjunct professor of infectious diseases at MGR Medical University and other institutes. He's also the director of Capstone Multi-Specialty Clinic in Chennai. Dr. Ramasubramanian did his MBBS from Madras Medical College, MD Internal Medicine from PGI Chandigarh, and trained in infectious diseases and HIV in the UK. He acquired his MRCP and diploma at the London School of Tropical Medicine, and he played a pioneering role in establishing infectious as a specialty in India. Dr. Ramasubramanian has authored several research publications and chapters in textbooks. He's currently the president of the Clinical Infectious Diseases and also a member of the European Society of Clinical Microbiology and Infectious Diseases International Affairs Subcommittee. Dr. Ramasubramanian is a passionate teacher and a sought-after speaker at various conferences and CMEs. His informative podcasts during COVID were a boon to doctors and general public alike. Thank you, Dr. Ramasub, for making time for Marvelous Medicine, and welcome back once again to Marvelous Medicine. Moderating the session will be Dr. Akhilesh Kunur. He's the professor respiratory medicine at Amrita Institute, Kochi. Akhilesh did his MBBS from TD Medical College, Alapura, and MD in pulmonary medicine from SCB Medical College, Cuttack. Akhilesh received his pulmonary rehabilitation certificate from the American Association of Cardiovascular and Pulmonary Rehabilitation and American Association of Respiratory Care, and he is a certified tobacco cessation specialist. Akhilesh has 40 publications to his credit and is a member of several working groups. Areas of interest are COPD, pulmonary rehabilitation, tuberculosis, and public health. The coordinator of the Amrita Pulmonary Rehabilitation Program and is the vice chairman of the state task force of the National TB Elimination Program. Thank you, Akhilesh, and thank you, Suma Balan, for introducing me to Akhilesh. My heartfelt gratitude to Dr. Ramya Sampath, who is joining us at the last minute because Dr. Bhagat got a family emergency. Ramya is currently the visiting consultant at MGM Healthcare, Bilrath Hospitals, and Capstone Clinic at Chennai. She did her MBBS from PSG Medical College, Coimbatore, and MD and DNB in Psychiatry from Government Medical College, Trivandrum. Ramya is academically oriented and has presented papers in regional and national conferences. She's a columnist for mental health in BBC Tamil site, a women's exclusive magazine. Conducts interactive awareness talks on television and All India Radio regarding common psychiatric issues. She also gives talks in schools, colleges, and corporates, sensitizing the public about the importance of psychological well-being. Her areas of interest are consultation liaison, psychiatry, and women's mental health. Thank you, Ramya, for agreeing to do this at an extremely short notice. And thank you, Dr. Ramasubramanian, for getting Ramya on board. Over to you.
Thank you very much, Dr. Vidya. It's a pleasure to be back with you and Marvelous Medicine once again. And as Dr. Vidya mentioned, I shall be talking to you over the next about 40 minutes or so on is it time to sing the Requiem for COVID? Are we seeing the end of it, or is it just another transient somnolence before it picks up again? Yeah, I hope you can all see my screen. I grew up studying. Can you all see the screen? Sorry.
Yes, we can.
Okay. I grew up reading Amar Chitra Kathas, and this always fascinates me. The cartoon, which is titled Vaccine Optimism, Puranic Tales of Hope and Delusion. So I think this is very, very apt with regard to COVID and COVID vaccines. And let us see whether this is actually coming true. So this I checked out, I think a few days ago. This says I checked up on a couple of days ago, but the statistics is of the 14th of June, 2023. There have been about 280 86,000 cases in the last 7 days. Total cumulative cases of COVID is about 767 million, and almost 7 million people have died because of COVID. Pretty daunting statistics. If you look at it by region, you'll find that Europe has the highest with almost 276 million confirmed cases, Western Pacific 204, the Americas 193, and Southeast Asia 61 million. A lot of this may have to do with the number of cases tested, because in the developed world, Europe and Americas, definitely a lot more people would have been tested when compared to the Southern Bloc. If you look at it country-wise, US has the highest number of documented cases, 103 million, China almost 100 million, India 45 million, and you'll see that the others are following behind. So my talk over the next about 40 minutes or so, I said, would be covering the treatment of COVID in 2023, both outpatient and inpatient, the infection control aspects, just to mention, and the impact of masks, the scare we had with regard to Mucor, the prevention through vaccination, what is a current recommendation for vaccinations, few words about long COVID, and where are we now, or what can we look forward to. If you look at the prioritization of outpatients with regard to treatment of COVID, it is very clear that younger people without comorbidities who have been vaccinated and had their booster shots also probably are the safest group. The tier 1 would involve immunocompromised individuals with or without vaccination. People who are over the age of 65, even if they are vaccinated, they are also at risk. People who are also at severe risk of severe diseases, though, are those over the age of 65, typically with comorbidities. So if you are under 65, if you have had your shots, I think you need not worry about COVID being any risk to you in the foreseeable future. If you look at the treatment of all outpatients with COVID, we have, as I said, the treatment should be targeting those who are at a higher risk of progressing to severe COVID-19. There are 3 therapies available, Paxlovid, or a boosted ritonavir with nirmatrelvir. We have remdesivir, and we have molnupiravir. Now, again, I repeat, these are targeting people who are at high risk of complications, which is mainly the unvaccinated, the vaccinated over the age of 65, or people under 65 who have a significant immunocompromised status, or who may have multiple comorbidities, including diabetes, heart failure, renal failure, and others. So the preferred drug is Paxlovid. This is believed to decrease the risk of hospitalization almost 6-fold times. So this is the best we have so far. It is recommended for everybody over the age of 12. It can be given in patients with renal failure and probably mild to moderate liver failure also. You can give this medicine. The only problem with this, or shall I say, the only 2 problems with this drug are the fact that, one, it has a lot of drug interactions, including several statins, several other drugs, because it has ritonavir, which is a very, very strong liver enzyme inducer. And the other problem is there is a possibility of what we see as rebound phenomenon. So people who have been given Paxlovid, once they recover, you stop the medicines, after a few days, they can have a recurrence of symptoms due to a rebound explosion of multiplication of COVID virus, and there is a recurrence of symptoms. So these are the 2 main side effects seen with Paxlovid. In those people who cannot be given Paxlovid for various reasons, the other alternative is remdesivir. We all have very good experience with remdesivir because this was used significantly both in treating patients who were required oxygen and who were hospitalized, and subsequently those who were at risk of developing complications within 7 days of onset of symptoms to prevent hospitalization. The main problem is liver toxicity, but it is very well tolerated. Both Paxlovid and molnupiravir have to be started within 5 days of onset of symptoms, whereas the window period for remdesivir is up to 7 days. If you're using remdesivir to prevent hospitalization, the dose is 200 milligrams on day 1, followed by day 2 and 3. Only 3 doses second and third day's dose is 100 milligrams. If you're using remdesivir in the treatment of hospitalized patients beyond 7, 8, 9, whatever days, people who are requiring oxygen, but not yet landed up on the ventilator, the duration of therapy was 5 days, and people on the ventilator up to 10 days. The first day's dose is always 200 and subsequently 100 milligrams a day. Molnupiravir is a very poor choice amongst the three. It is recommended for adults over the age of 21, does not have drug interactions, but it has teratogenicity and so cannot be used for pregnant women. It is believed to probably reduce the risk of hospitalization only by 30%. So between the three, it has the lowest preference, and it also does not act very well in diabetics and in elderly women. So the role of molnupiravir is limited. So when you cannot use Paxlovid or remdesivir, because remdesivir may have to be given parenterally, molnupiravir is an option. It is the Paxlovid has been given full grant approval by the FDA for use, and we have several Indian brands also currently available for treatment. But in vaccinated younger individuals, the role of these drugs is very, very minimal. It has also been shown that the real-world effectiveness of Paxlovid in preventing COVID-associated hospitalization, it reduces the risk among incompletely vaccinated high-risk outpatients and among some subgroups of completely vaccinated high-risk patients. So reserve treatment in the outpatient with these drugs to only those who are unvaccinated or who are maybe vaccinated but are immunocompromised, but very elderly or have multiple comorbidities. So this is the indication and selection of COVID therapy. This is from UpToDate. The latest one, those who are eligible for COVID treatment if they are over 65 or immunocompromised, as I said, or have multiple comorbidities, you need to start treatment within 5 days if you're going to use Paxlovid or molnupiravir. If it is within 7 days, you can use remdesivir. You cannot use Paxlovid if the you can use Paxlovid if the one second. Yeah, the creatinine clearance is less than 30. You cannot use Paxlovid. In that situation, you can use remdesivir. But if it is not very bad renal failure or only mild hepatic failure, you can still use Paxlovid. What about the isolation precaution? There has been a lot of confusion. Is it 14 days? Is it 10 days? Is it 7 days? This is probably the one which is well accepted. All patients you need to isolate at home if they are stable for 5 days, assuming day 0 is the onset of symptoms, if they are symptomatic. If they don't have symptoms and they are detected positive without symptoms for whatever reason, then the day of the test is taken as day 0. Generally, 5 days isolation is advised. Beyond day 6, if they have no fever and the symptoms are improving, they can go back to work, but they are advised to wear a mask. For people who have moderate to severe disease, who may be hospitalized, the duration, generally what we used to do in our population is those who have moderate disease but who are not ventilated, we used to isolate them for 14 days because they have a longer possibility of shedding the virus. For those who had been on the ventilator, 3 weeks is what we kept as the outer limit of isolation. This is the continuation of the same chart. So after 5 days from 6th day, end of home isolation, but they are advised to wear mask. If they did not have resolution of symptoms, it was advised that they stay home for up to 10 days. In India, most of us advised to avoid this confusion, 7 days of isolation, and after that you were free to go if they had only a mild disease and their symptoms had settled down. What about hospitalized patients? How differently do you need to treat them? For hospitalized patients, for reasons who required hospitalization other than COVID, they can be managed as those who would you manage in the outpatients. Hospitalized patients not requiring oxygen, then dexamethasone is not indicated. They can be given remdesivir. If it is more than 7 days, definitely a 5-day course is indicated. Those who are hospitalized and requiring oxygen, along with remdesivir, you need to use steroids also. And in patients who, in spite of receiving dexamethasone, continue to deteriorate, the options are, earlier we only had tocilizumab. We now also have the use of oral baricitinib. This is one of the JAK inhibitors. This is very well tolerated. So they have two options in patients who are in hospital requiring oxygen who may continue to deteriorate. Those who are requiring high concentration of oxygen through HFNC or NIV, again require DEXA, either oral baricitinib or tocilizumab with remdesivir. Those who are requiring ECMO or who are sick on the ventilator, then there is probably no role for remdesivir. We give only dexamethasone and baricitinib or tocilizumab. So this is now reasonably well accepted as the approach to treating both outpatients and inpatients. There were a lot of papers published during times of COVID. There was a surge of papers, and we had several authors coming in with various hypotheses, but this has now been crystallized to decide what therapies are definitely not recommended. HCQS, azithromycin and antibiotics, ivermectin, fluvoxamine, colchicine, steroids, anticoagulants, metformin, vitamin D, and zinc. Now, please note, I've written that metformin is not indicated or not recommended, but this may be, there may be some controversial situations coming up later during the talk. But please remember, there is absolutely no role for these agents in the treatment of acute COVID infection. One more offshoot is that we realize that even though N95 was strongly recommended, there have been several papers looking at the adverse problems caused due to masking, especially N95 mask. This is a very recent study which came, I think, a couple of months ago, looked at, compared between those who are not wearing a mask and wearing a mask. The heart rate went up, the energy expenditure went up, and the fat oxidation also went up, thereby decreasing the concentration ability, decreasing sometimes the cognitive ability. And there has been a lot of concern regarding the use of doing work with an N95 mask for prolonged periods of time. So now we generally use only a surgical mask in most situations, and N95 is reserved only in situations where there is a possibility of aerosolization, typically in the hospital and in the ICU. The third topic I wanted to cover is the association of mucormycosis with COVID. We saw again there was an explosion of cases typically seen in India. Even though India, even before COVID, was the mucor capital of the world, we found that COVID was associated with a number of cases of severe, invasive mucormycosis, which caused a lot of problems. This is one of the most recent papers which looked at a large cohort of almost 1,000 cases in various parts of the world. And you'll find that India figures very, very strongly in this. More than 500 cases were reported associated with COVID. And a significant number of people also died because of COVID. There were a lot of comorbidities associated with the occurrence of COVID, occurrence of mucor in patients who had COVID. It was generally seen that patients who developed COVID were more, or shall I say, were older than patients who did not have COVID but got mucormycosis. So patients with COVID were older, they had diabetes, they had uncontrolled sugars, and also multiple comorbidities, which included hypertension, hypothyroidism, typically saying that they were elderly people who were sick due to COVID. There were a lot of other associations seen. The mortality you'll see was very high, almost 60% to 70% to almost 80% in patients who ended up on the ventilator with severe COVID and who also developed mucormycosis. So if you had COVID and developed mucor, the outcomes were not great. The species associated with COVID included Rhizopus, Rhizomucor, and typically Rhizopus microsporus was the main species of mucor associated with COVID. And you see that even though a lot of continents showed that various species were seen, the bulk of the cases occurred in India only. These were the several sites of mucor. You find that the highest mortality is seen probably in patients with gastrointestinal mucor, pulmonary mucor, and renal mucor, and also, apart from disseminated mucor, also rhino-orbitocerebral mucor. So once it started invading, it is an angio-invasive fungus. So it enters the blood vessels and spreads very easily, causing infarction and even affecting distal tissues. So COVID in mucor and COVID is bad news. But having said that, a lot of younger people did well if they were treated early. In India, there were several places where they looked at trying to preserve. Normally, the treatment of mucor has three components. One, surgical debridement to remove or debulk as much of infected tissue as possible. 2, control the underlying condition, which is mainly sugars. And 3, antifungals, which was liposomal amphotericin is what is recommended. In India, a lot of places conserved tissue. They resorted to less extensive tissue resection and debridement and concentrated on giving antifungals, or even topical. They used to spray amphotericin through the nasal cavity into the sinuses, and a lot of people did well. After a week of IV amphotericin, a lot of places, because of availability and also cost, changed over to oral posaconazole or oral isavuconazole, and the outcomes were not too bad in the younger population. The predictors of mortality were severe COVID, elderly people, malignancy, and several other comorbidities. We'll move to the next topic of my lecture, which is to do with vaccines. And I found this very, very interesting, an article in the Lancet way back in 1937, which compared mathematics and medicine, or shall I say, put together both, and stated that statistics are curious things. They offered one of the few examples in which the use or abuse of mathematical models tends to induce a strong emotional reaction in non-mathematical minds. This is because statisticians apply to problems in which we are interested a technique we do not understand. And this is very true almost 100 years later. People have difficulty in understanding the mathematical modeling and application of statistics to medicine. So going to the types of COVID vaccines, again, there was an explosion of vaccines which came out for COVID. The various platforms which were introduced were the DNA and the RNA platform, live attenuated we knew, inactivated we knew, subunit we know, and also the viral vector, which has recently come in. So the mRNA vaccines were the first time vaccines introduced on this platform were for COVID, which has come out with resounding results. If you look at the number of vaccines still in clinical development, almost 183, in preclinical, almost 200. So there has been a huge number of companies coming out with research on vaccines. If you look at the trials, 242 vaccine candidates, 821 vaccine trials, and 80 countries which came out with trials for vaccines. These were the vaccines which till recently were available. The mRNA vaccines include the Pfizer and the Moderna vaccines, the vector-mediated, which is Covishield and Sputnik using the adenovirus vector, inactivated Covaxin of India from Bharat Biotech, DNA Zycov-D from Zydus, protein subunit Novavax, and just, I think, 2 days ago or even yesterday, the first mRNA vaccine which was manufactured in India by Genova, called the Gencovax, is likely to be licensed in India in the next 2 to 3 weeks. This is the first mRNA vaccine from India, which will be licensed. And the one good thing I have read about is that unlike Pfizer and Moderna, which have to be stored at -40 degrees centigrade, these vaccines can be stored between 2 to 8 degrees centigrade like any other vaccine. So this new mRNA vaccine from India appears very promising, but it is surprising that no vaccines are available in India and most places against COVID. So if you need to travel somewhere right now and you need another dose, you can't get anything in India because there is no vaccine available. I may be wrong, but at least in Chennai, that is the situation. And to talk about statistics and mathematical modeling, when you say vaccine efficacy and say that the vaccine is efficacious 80%, it does not mean that the vaccine will work only 80% of the time. It means that in a vaccinated population, the vaccine will protect 80% of the population if they come in contact with the virus. So it will be effective. It is probably how a human responds to the vaccine rather than the vaccine being efficacious. And the idea of vaccine protection is you vaccinate a significant majority of the population, you create what we all have heard as herd immunity. So when more people get vaccinated, fewer people are likely to come into contact with the virus, and the vaccine may not spread as efficiently in the vaccinated population. So this is the rationale behind getting the whole community vaccinated, rather than even if a few of you take it, you only may be protected, but the community may come down very badly. But the question which a lot of people asked was, which vaccine do we take? Is Covishield better? Is Covaxin better, or shall I fly down to the US and get the Pfizer vaccines? A lot of people ask me. The one important thing all of us have to remember is the WHO has said that if a vaccine is efficacious more than 50% of the time, it's a good vaccine. And if you look at all these vaccines, though the number percentages may vary, for example, Pfizer is somewhere in the region of about 93. Moderna is also in the region of 92, 93. The AstraZeneca vaccine is lower down at 66. And let us give this Sputnik vaccine is about 90. And the Covaxin, which is from Bharat Biotech, figures around 80. So all these are good vaccines. And to make it more simple, you find that Moderna, Novavax, and Pfizer are probably more efficacious than Covaxin, J&J vaccine, or the AstraZeneca Covishield. But whichever vaccine you take, it has been very clearly shown, I think it will come later, that it prevents hospitalizations, prevents serious complications, and prevents death in a significant number of population. What about the side effects? Side effects, even though a lot of media hype came out for side effects, anaphylaxis was initially seen in the Pfizer and the Moderna mRNA vaccines, which was found to have no specific correlation with any other factor. So the only advice was observe anybody for at least half an hour after vaccination. The thrombotic thrombosis with thrombocytopenia syndrome, which was vaccine related, typically seen after the Covishield and the J&J and the Janssen vaccines, were also seen, but in a minuscule of patients compared to the risk of thrombosis associated with the COVID acute infection. Cases of myocarditis and pericarditis were seen in adolescents and young adults, typically after the mRNA vaccines. And Covishield, as I said, was also associated with thrombotic thrombocytopenic purpura, but the incidence was very, very rare. So when you look at the benefit of the vaccine for the whole community, I think you may have to accept a very small risk of complications in individual patients. Are these vaccines effective for the endless variants which we are seeing now? When cases increase and transmission accelerates, it's more likely that new dangerous and more transmissible variants will emerge and can spread more easily or cause severe illness. Based on what we know so far, vaccines are proving effective against existing variants in preventing disease, severe disease, hospitalization, and death. However, some variants may have a slight impact on the ability of the vaccines to guard against mild disease and infection. So this basically tells us that vaccinations do not prevent the disease, but only protects us from severe disease, hospitalization, and death. So the bottom line is, whatever the type of vaccine, it still helps to prevent severity of disease, hospitalization, and death. We have seen that the Omicron lineage, which started with the BA.1 and has now gone down to BA.5, which has made several of the monoclonal antibodies ineffective. Still, even though there is a vaccine escape, they still protect against, the vaccines still protect against severe disease caused by Omicron. But one thing is, at present, especially those who are living in India, have to understand that the current recommendations worldwide is that there is no role for a booster vaccine, which is a monovalent vaccine. What we all had as Covishield, Covaxin, and others were all monovalent vaccines. The currently available bivalent vaccines from Pfizer and Moderna are what are recommended. The new GenCovac, which is coming in India, the mRNA vaccine, has both a monovalent and a bivalent preparation, which is likely to come in. So even in patients who are subjected to Omicron infections who had the monovalent vaccines, it was shown that vaccination enhanced protection among persons, especially if they have had a previous infection, and the best immunity came in patients who had an infection followed by the vaccine, even if it was a monovalent vaccine. Are there any contraindication to the vaccine? What about anaphylaxis? Only if the anaphylaxis had been to a COVID vaccine, it was contraindicated. Otherwise, there was no contraindication. Severe allergic reactions not related to vaccines or other agents were not contraindications. And individuals who have had anaphylaxis to other agents, all needed to be done was to observe them for 30 minutes after vaccination. Is there a role of aspirin before vaccination? No. Do you need to do any antibody tests or check your CRP before vaccinations? No. Can you vaccinate in pregnancy? Yes, especially because COVID in pregnancy is associated with a poor outcome. Can you vaccinate people who have had bad strokes, who are on blood thinners? Yes, yes, yes. Vaccination in the immunosuppressed, strongly recommended, though the efficacy may not be good. Vaccination after COVID infection after 6 months. Vaccination after monoclonal antibodies, at least after 3 months. What about the current recommendations? Good news, your cholesterol has stayed the same, but the research findings have changed. This is exactly what we are seeing with COVID, starting from the times when vaccines were purported to prevent occurrence of infection. We later realized it only minimizes the severity of infection. These are the current recommendations from the CDC. Let me say, for people over the age of 18, the last 3 columns, 2 doses of Pfizer and Moderna were advised, and 1 dose of Johnson & Johnson. Now, in immunocompromised persons, an additional dose after 1 month is recommended. So apart from the 2 doses, a 3rd dose is part of the initial schedule of vaccine for people who may be immunocompromised. This is again a flow chart. I won't go into the details, but basically it tells you that if you are immunocompetent, 2 doses followed by a booster after at least 4 to 6 months is recommended, and it should be a bivalent one. So if you have not had a bivalent dose initially, your booster should be bivalent. Whereas if you are immunocompromised, 3 doses followed again by a booster. And even if you take booster, the immune correlates of protection, which is mainly the antibodies which we can measure, come down 4 to 6 months after the vaccination. The confusion has been, so does it mean that everybody needs to take repeated boosters every 6 months, even after your original vaccine, a bivalent vaccine? This is from the Australian guidelines, which is a little more conservative. People between the ages of 18 and 64 at risk, a booster is recommended. Whereas if there is no risk factor, you can consider a booster. So they have toned down. They have toned down the recommendations for booster, and they have not mentioned about repeated boosters, but they have also said that your booster should be a bivalent one. These are the conditions where you can expect that the response to COVID vaccine may be suboptimal: malignancies, hematological malignancies, solid organ transplants, people on CAR-T receptor therapy or other biologicals, immunodeficiency, advanced HIV, people on corticosteroids or several other immunosuppressive agents. So these are the people you need to be careful. Even if they are vaccinated, they will have suboptimal response, which we shall see subsequently. A few slides on the immunocompromised. People with malignancy have poor outcomes with COVID. We have seen that the seroconversion in people is much, much lesser. Now, people, healthy controls have a, if you take it as 1 as the response rate, people with cancer and hematological malignancies seroconvert very, very badly. Even the immune response is very poor. And the waning of immune protection is also faster if they have immunosuppression due to cancer. So they do not respond well, and their immune system also weakens much faster. And probably mRNA is believed to be probably the most effective vaccine among all the vaccines available. Even in these, with mRNA vaccines, the response is not great in these populations. But having said that, vaccines definitely help, even though the response is not as adequate or optimal as the immunocompetent. You find compared to the pre-vaccine era, the mortality is much, much lower, and the chances of survival is much greater in the vaccinated people. The worst is with hematological. So it is recommended that apart from the initial doses, boosters are definitely warranted for people with cancer, solid organ transplant, hematological malignancies, whose response may be low. And a 4th dose is also recommended. And the more boosters you give, at least this study has shown that you keep the immune system working better and have better outcomes with COVID. And the safety of the vaccines is also very, very acceptable in patients who are immunosuppressed. So apart from the population of immunosuppressed patients, in most other situations, 2 doses vaccines with 1 booster is probably adequate. Only in the severely immunocompromised, 3 doses of primary followed by a bivalent booster, and probably repeated boosters every 6 months if they continue to be severely immunosuppressed is the current recommendation. Lastly, the ECIL recommendation says patients with hematological malignancies. This is the European recommendations. full doses with 3 doses, additional booster after 3 months. Patients who have been vaccinated during treatment should be assessed every 3 to 6 months to see if they need to be revaccinated if they have low antibody titers. COVID vaccination should not delay treatment of the underlying disease. So these are the recommendations. Lastly, even in people who are vaccinated, who have had their booster doses, the response to COVID is not as good as people who have been healthy. So the bottom line is you need to understand and improve efficacy through immunity. So we need to probably improve communication and come up with altered, or shall I say, novel ways to administer the vaccine, the schedule to improve immune response. Lastly, I'm going to conclude with the concept of long COVID. Does it really exist? The 100% genuine fake shop. So are people who have symptoms which persist a month beyond an acute COVID infection are just, for a loss of a better word, whiners? Or are they really troubled and is there a problem? There's been a lot of controversy about this. The recent study, which was again done this year only in the epidemiology of long COVID disease, this was published this year but conducted earlier between June to July 2022, observed that the number of cases was almost 7.3%, almost 1 in 10 persons who have recovered from COVID ended up with long COVID in the US, almost double the number seen in UK. There was a high burden of long COVID with substantial variability in the prevalence of SARS-CoV-2 and risk factors, typically more often seen in women, more often seen in women with comorbidities, and more often seen in the unvaccinated. So this was the result of this study, that more women who are having comorbidities and unvaccinated ended up. Studies have shown that the risk of long COVID increases with the severity of the disease, even though a significant number of non-hospitalized also had the disease. I apologize for this very busy slide, but again, this said that people, the same risk factors which I had mentioned before, plus the fact that people who are diabetic had a higher risk of long COVID, people who had other immunological conditions, including SLE and other autoimmune syndromes and urticarial disease. And they also noticed people with a low socioeconomic status or a low income, and people belong to the Hispanic, race. They seem to have a higher possibility of COVID. So was there some commonality which linked this? Poor Hispanic individuals, typically women who had comorbidities. So there's still a lot of questions about the validity of this condition of long COVID. But what are the symptoms of long COVID? It could be fatigue, it could be dyspnea, chest discomfort, cough, and also anosmia. Less common physical symptoms will include joint pain, headache, dryness, rhinitis, altered taste, poor appetite, dizziness, vertigo, myalgia, insomnia, alopecia, sweating, and diarrhea. And a lot of them complain of psychological and neurocognitive diseases, conditions like post-traumatic stress disorder, impaired memory and cognition, poor concentration, anxiety, and depression. Of course, I think palpitations have been missed here, but the occurrence of what is called POTS, postural orthostatic tachycardia syndrome, is a major manifestation of long COVID. You'll see that COVID affects several organs. In lungs, it can cause cough and dyspnea due to abnormal gas exchange, autoimmunity and a mast cell activation syndrome. You can have diabetes and pancreatic injury, abdominal pain and nausea resulting from gut dysbiosis and viral persistence, fog, you call it mental fog, cognitive impairment, fatigue, disordered sleep, memory loss, tinnitus, all because of dysautonomia, something like the chronic fatigue syndrome, which has now been attributed to Epstein-Barr virus, reduced cerebral blood flow, neuropathy, sometimes associated with renal insufficiencies, fatigue related to vascular issues, and also erectile dysfunction and menstrual irregularities. All this has been seen with long COVID. In fact, patients who have long COVID have a higher risk of these conditions within the first 1 year: pulmonary embolism, cardiac arrest, heart failure, death, and stroke and diabetes. Long COVID is also associated with, as I said, dysautonomia, the POTS syndrome, myalgic encephalomyelitis, and chronic fatigue syndrome. And people who have breakthrough infection also have a higher risk of complications of various systems. It is believed that the mechanism of long COVID could be related to immune dysregulation, dysbiosis, microbiota dysbiosis, autoimmunity, viral persistence and replication, blood clotting, which can lead to vascular problems, and dysfunctional neurological signaling. So these are all the mechanisms which have been put forward to explain the various symptoms of long COVID. And again, I apologize, but various therapies have been mentioned for long COVID, and I hope Dr. Ramya can throw light on a few of these. There is cognitive dysfunction, you resort to cognitive pacing. For fatigue, you give coenzyme Q. For pain, fatigue, and neuralgic symptoms, low-dose naltrexone. In other words, there is no specific treatment. The whole concept of long COVID, is it a well-defined entity? Is there a test, a diagnostic test? Are there factors which will specifically, you give Paxlovid? So for viral persistence, it says you give Paxlovid. So can there be specific agents you use? It is still all very, very nebulous. There are a couple of articles. I looked at the effect of cognitive behavioral therapy, CBT, in targeting severe fatigue. One thing is very clear. If you expose, or should you say, if you put people with long COVID under stress or physical activity, if they are subjected to exercise, their symptoms actually worsen. So it is strongly recommended not to advise exercise for people who are having long COVID or recovering with symptoms. But among patients who are mainly non-hospitalized and self-referred, cognitive behavioral therapy was effective in reducing fatigue, and the positive effect was sustained at a 6-month follow-up. So this seems to be interesting in these population. Now, one more study which came up, the role of outpatient treatment of COVID-19. It was found that outpatient treatment with metformin during acute COVID reduced incidence of long COVID by about 41%, an absolute reduction of 4.1 compared with placebo. If you remember, I mentioned that metformin is not recommended as a treatment for acute COVID, but this study, which was published, I think, just a month ago, said that use of metformin in acute COVID prevented the sequelae of long COVID in a significant number of population. In fact, this paper has been looked upon as a sort of a very revolutionary paper, because this was the first paper where, when you're having doubts about the existence of a condition, this paper showed that yes, by defining the symptoms based on a questionnaire and putting a treatment to it, which actually helped patients, this confirms the entity of long COVID as such and how it can be prevented. This is something which is the reverse of Koch's postulates, where you say by injecting the organism recovered from a patient to another patient, you create the disease. This is the question of, this has been referred to as a therapeutic validation principle, whereby you are not clear of the disease, but you define a disease and you put a treatment and say it improves, and thereby you show, yes, there is actually a condition which needs to be looked into. So lastly, we need to look at the main problem we are now facing is long COVID, and I hope that Ramya and Dr. Akhilesh can share some of their views on how it is and what we can do about it. Lastly, this is a paper which I just came across today. This has been published on June 22nd, 2023. The origins of COVID. Is it accidental? Is it natural? Is it deliberate? Most of us think it is natural, whether it was deliberate, but because of the political intervention to the medical science, there has been a lot of muddying of waters. We still don't know. There have been a lot of conspiracy theories, but does it actually make a difference in how we manage? Probably not, but it will make a difference in how future epidemics or pandemics can arise. So the last two slides, what has actually COVID taught us? If you really ask me, this is what I found. Google has helped create doctors since 1998. During times of COVID, most patients became doctors. I had patients who landed up in my clinic with the monoclonal antibody saying that please infuse this because I need it. I know doctors were told more often what to do than requested by patients what they can do to treat them. So this was one of the major revelations of COVID, according to me. But how is this evolving? Yes, we have now resulted into jugaad. We are now using masks for other purposes. We have seen that the Newton's fourth law of motion was evidenced by the fact that for every action, there is an equal and opposite reaction, plus a social media overreaction, which was really visible during times of COVID. We also saw that there was a lot of questioning of scientific validity. Are you going to get vaccinated? No, they haven't finished human studies. So all this came in times of COVID. We were in a rush. We had to show that people were dying and we had to do something about it. But lastly, I think what I realized that in spite of all this, one, knowing the benefits of vaccines, people still would resort more happily to Botox rather than to vaccines. Both were injections. And most importantly, after 3 million years of evolution, we only have lost the hair. We still think like we used to before, having known the fact that we have faced an influenza before and COVID now. We are still going back to how we lived pre-COVID days. Is that right? I don't know. But as I said, we have not learned much. We continue to live the way we are. And to conclude, what are my thoughts on how COVID is going to pan out? I feel it will become more like an influenza virus. We will have the vaccines. We will take our periodic vaccines. We will have times when everything is hunky-dory. We will have strains which may come up other than the Omicron, which may cause, like the H1N1, lot of loss of lives in future. So I think probably we will learn to live with it. And we can only hope that the severity will come down in the next few years, and maybe vaccinations will become more few and far in between later. So I'm going to stop sharing now. I think it is 8:50, exactly 45 minutes I've spoken. And I'm going to ask probably Dr. Akhilesh or Dr. Ramya now to say a few words. Unless Dr. Vidya, you have something planned.
No. Thank you, Dr. Ramasubramanian, and sorry for the delay in starting. Over to you, Dr. Akhilesh.
Thank you, madam and sir, for an excellent review. After a long.
Akhilesh, are you there?
Hello. Can you hear, madam?
Yes.
Thank you, madam.
Can't see you though.
No, we can see him. At least I can see him.
We can see him, Vidya.
Yeah. Okay.
After a long gap, actually, I'm hearing a talk on this COVID, and there are a lot of talks on these vaccines are there now. But I just want to ask one question, and then there are a lot of confusion regarding the advertisements on vaccinations, especially in pregnant women. If there is a high prevalence of thrombotic events, is there such high-risk patients, whether specified or not, how, if so, what type of vaccine we will give? That's one question, sir. Then I will go with my discussions.
I think the best information regarding vaccines is available from the mRNA platform only. We have seen that both Moderna and Pfizer vaccines have been very, very effective. They have had some side effects, but most of them have been mild. The occurrence of pericarditis with the mRNA vaccines in the younger adolescents and adults has been a problem. But again, the number of people who were hospitalized because of this was very, very small, and people who succumbed to this was very, very uncommon. So yes, vaccines can cause problems, but if you looked at, like I said, the benefit versus the risk of vaccines are strongly recommended for most categories of people. And the advice would be, in India, whichever bivalent vaccine you can lay your hands upon subsequently in a population, typically very elderly, people who are immunocompromised, please go ahead with a bivalent vaccine would be my advice.
Thank you, sir. Just to share about this long COVID and the COVID, now we are not seeing. Sorry, sir. Just to share about the our views on this long COVID, especially as sir taught. The thing is that we are seeing a good number of people, especially who had the last variety, that Omicron variant, presenting with cough, wheezing, and all these things. And when we are doing the pulmonary function test, most of them have a smaller way of obstruction, or a mixed type of pulmonary functions. There is a post COVID inflammatory reaction, mostly must have heart. So I think this patient always present with recurrent infections or recurrent wheezing or exceptional dyspnea type of listing, type of patterns. And good number of patients are responding with inhalers, not all. And in some subset of patients, we have to give them this pulmonary rehabilitation also. Pulmonary rehabilitation is especially after 1 or 3 months. Maximum after 3 months, if the symptoms are not subsiding, most of the patients are benefiting with the pulmonary rehabilitation. And second thing is that number of infections, especially a few months back also we had patients with not COVID, the post-COVID patients presenting with secondary infections. The frequency of infections happening in these post-COVID patients, I think it is little more now, maybe viral or maybe even fungal infection like aspergillosis also we are seeing in much more amount. This is what I have seen in our set of patients. Yes, the mask had a wonderful effect, and we have even published the problems with the mask also, because a lot of patients were complaining, especially with N95 mask, with suffocation, and they are not able to communicate properly. There are a lot of headache also. There was another issue was the headache. So that is a significant issue. And nowadays, again, the habit of wearing mask is also reduced. So these are our using the pulmonary aspect. Thrombotic components, I think over the last few months we have not seen that much, but mainly these recurrent infections and the airway component what we are seeing, not parameter component.
But do you come across a lot of patients who complain of breathlessness or palpitation after COVID? Is that a significant number? Because according to the US study, almost 8% had it. So do we see that much in India?
Yes, sir. Yes, sir. In the initial COVID time, just within first within 1 month itself, most of a good number of patients had palpitation. That was one of the main symptoms of palpitation. Then this exceptional breathlessness.
Right.
And this after this Omicron variant, what we are seeing is mainly bronchospasm like features. It was not prevalent in the second variety, Delta variety. That was mainly post fibrosis exception dyspnea type of pattern.
Dr. Ramya, what is your thoughts on what are your thoughts on the long COVID? Because we do come across a lot of patients who have very, very vague symptoms. So do you come across patients? Because one thing I definitely noticed was the occurrence of mental disease in children was phenomenally high. You know, children who were off school for a year, you know, a lot of them went through problems. So what are your thoughts on long COVID specifically to do with mental health?
Thank you so much, sir, for the excellent opportunity. It's always a pleasure to, interact with you. Sir, if we can just conceptualize on the long COVID per se. So definitely there are, 2-3 ways of looking at it. One is the biological vulnerability of people itself has increased. If you look at the biopsychosocial model of mental illness, the biological vulnerability itself has increased because COVID has a lot of repercussions on the neuronal level. So, and in addition to the other infection, the kind of stigma and the other psychological issues, lot of unemployment, and as you rightly mentioned, children attending classes only online, there is no scope for social skills. So life has become totally different during the time of COVID. So long COVID, when everybody is like, psychologically, the most highest form of stressor is uncertainty. So if they are sure that something is going to happen or something can be controlled, then the anxiety levels at least come down. So to deal with uncertainty and lot of unanswered questions, people are still having an impact or the scar of what they have underwent. as you rightly mentioned, post-traumatic stress disorder, especially children when they are having a developing brain, which is more vulnerable to stress than an adult brain. And even in adults, when there is so much of information overload and there's a constant threat that is imposed by the social media, as you rightly mentioned, as an overreaction. So that leaves them with continuous overthinking, sleepless nights, and also on the other end, like COVID survivors, like similar to a cancer survivor, somebody who was like, I mean, lost somebody very significant to COVID. How are they going to cope up? So a lot of these psychological issues are very, very explicit. So one person would have passed away, but the other living spouse doesn't know how to deal with life because it is totally an unanticipated demise or something that has turned out as a shock on the whole family. Also in children, especially gadget addiction is very high. So because of the online classes and their access to a lot of gadgets, a lot of children, we tend to see their gadget use has increased exponentially during the COVID period. And that has replaced the priority for them to socialize in real time, to play or to meet with other children, to interact and other things. So that is one aspect of looking at things. And health anxiety is the single most common condition that we come across. So even if the child is having very trivial respiratory symptom or something, the parents are very overprotective and they are so panicked about what the child is undergoing, what they have to do to prevent it, things like that. Also because thanks to Google, as you rightly mentioned, like they come with a self-made diagnosis. They say they are having trauma, they are having panic attack. So it becomes totally confusing to how to address them on all fronts. So psychological impact on the biological level, on the psychological level, and even on the social level, the scar still remains from the psychological front is what I would say.
There are some questions which have come up. Should we continue to wear masks? At this point, in the last 3 months, I have probably seen only 2 cases of COVID. Yeah, probably more than 2, maybe about 10 or 15. Most of them have been incidentally detected in the hospital for various other admissions. There was only 2 days ago, I saw 2 patients in Chennai come down with COVID after a hospitalization. So it's difficult to say, yes, masks, especially surgical mask usage, has brought down the risk of not only COVID, but several other respiratory infections. But practically, it is very difficult to continue wearing masks religiously like we used to before. So to be practical, if you are in a situation where there is going to be crowd, you're going to be stuck in, in areas where there is poor ventilation, yes, mask is advised. Or if you're dealing with patients in close proximity, wear a mask. But in other situations, when you're going out with family, when you're in an open area or you're in an area which is well ventilated, I think you can get rid of masks. That would be more practical advice. There was recently news that mRNA is the cause of most cardiac complications. What do studies say? Yes, the Pfizer and Moderna vaccines were associated more with myo and pericarditis in the younger age group and adolescents. Apart from that, no, it is mainly the Johnson & Johnson and Covishield from AstraZeneca, which have been associated with thrombotic thrombocytopenia. Woody characteristic comment: if wearing N95 masks leads to fat oxidation, does it lead to weight loss? We need an endocrinologist to answer that. What about the after effects of something like IBS or IBD? Has it increased? That is intolerance to certain foods. Yes, as I said, no, because of long COVID, it could be it could be in the form of bowel irritability, symptoms of typically diarrhea, palpitation, anxiety, all that. But as I said, how many of that is defined? I think still they are recently, the questionnaires are a little more specific about it. Low saturation and happy hypoxia seen in long COVID patients. This is typically seen in patients who have had bad lung involvement due to disease. Again, I would like Dr. Akhilesh to comment on this. People who have had bad COVIDs, they recover well, but they are bordering around a saturation of 90% or even less in most situations. How much of this is going to harm them in the long run? I don't know. Probably Akhilesh can tell us.
Dr. Akhilesh would like to comment.
Yeah, this Long-term effect means these patients always means there are some pulmonary interstitial involvement may be there, or the reasons may be some thrombotic events. It can lead to a pulmonary hypertension and lead to other complications. That may be the long-term consequences.
Dr. Ramsub, in the beginning, there were some questions. You gave a list of drugs which are useless for treatment of COVID. In that, Dr. Nagasamy is asked, what about indomethacin?
Yes, indomethacin has been pushed, but we don't have any definitive recommendations of indomethacin safe. And I know Dr. Rajan Ravichandran, strongly encourages the use of indomethacin. But I have not come across enough data to say that it helps. So no, I don't use it. I don't recommend it.
And the other question Dr. Nagasamy had was mucormycosis explosion that we saw in India due to steroid use?
Probably, yes. I think it was not single, it was multifactorial. It was the occurrence of COVID, plus the use of steroids, plus the occurrence of hyperglycemia. All of them contributed. In fact, studies have shown that the COVID does not cause a predisposition to mucor to local reasons. It's not a respiratory, it's not a lung lesion, lung reason. It is some sort of a change which happens in the body because of COVID, which increases the risk. And this is probably right because we have come across patients who have not had hyperglycemia. Studies, they are not diabetics, they were not given steroids, they still had COVID. People in a situation where you would not suspect that COVID can occur in this situation, it happened. So it is definitely some way in which the COVID directly has an effect in changing the body and making it more predisposed to mucor. So that's all I can say.
The other question was, with all the media hype, would you still recommend Pfizer vaccine?
Yes. See, probably when you look at it now, when you see that COVID is very mild, Omicron probably, other than causing a little throat pain and fever for a couple of days, even in most people does not do anything, you would question how necessary the vaccine is. But having seen what had happened and having seen what difference vaccine can make, I would strongly, I'm a passionate advocate of vaccines. So yes, I would still think. Nothing is safe. I have seen people who take ciprofloxacin die of toxic epidermonecrolysis. Young kids die of TEN. You see that once, you will not write ciprofloxacin again. But we know what benefits antibiotics can give. So I think the side effects do happen. People can die due to unfortunate collateral damage. But if you look at the benefits of society at large, vaccines are definitely indicated. That's my opinion.
So the other question is, are there any markers to detect long COVID? Are there any studies in the pipeline or any biomarkers, anything?
No, nothing has been zoomed in on as yet. It's still a question of, questionnaires which we use to diagnose people who may have continuing symptoms beyond 1 month of acute COVID. Hopefully, things may get a little more clarity with time. We may come across a marker. We still don't have a diagnostic test. What do we say to pregnant women now if they want to take the first COVID vaccine? At this point in time, I would not rush into giving a pregnant woman COVID vaccine. If there are cases around and the person is unvaccinated, yes. But at this point, when we hardly see COVID in India, I'm talking about India, and the person is pregnant, I would advise mask and being a little more careful than giving the vaccine. Even though COVID vaccines have been found to be safe in pregnancy, I don't think there is enough evidence to say that, it's perfectly fine. I would still be a little wary. So in a situation where a woman is pregnant, there is COVID circulating, she's unvaccinated, yes, I would vaccinate her. But right now, I would advise only preventive measures, especially if she's going out of the house and those kind of measures, than rushing to vaccinating her, is my feeling. And second, in India, I don't think you are having any bivalent vaccine now for use. So monovalent may not help at all in a situation right now.
Ask one question. I'm Lata here. One more thing I wanted to know about vaccination. I mean, are there any studies going on whether we can do away with single vaccine or
Do away with?
just giving a single vaccine? It's better than not giving anything. Is there anything like that, or is it mandatory that they have the booster dose?
There is no mandatory request at all. See, the only mandate with vaccines there are actually two mandatory vaccine requirements which are legally mandated. One is yellow fever vaccine. The other is polio vaccine if you're going to certain areas in the world where there is still polio detected. Apart from that, vaccinations are entirely voluntary.
No, I'm not saying about that. I said, is it enough if they take one dose, or should they go ahead with a booster dose if they want to get vaccinated?
Booster dose typically in people over the age of 65 or if they are immunocompromised. Otherwise, two
But
doses.
the primary
I meant that the second
vaccination is
dose.
two doses, right?
Yes.
Yeah. Primary vaccination still remains two doses for majority of the population.
Yes.
I'm right, Dr. Ramsubramanian? Yeah.
Yes.
Is that what you were asking, Lata?
Yeah, that's what I was asking.
Yeah, it's still two doses of primary vaccination for the majority.
So just how I read about this pulmonary rehabilitation. This pulmonary rehabilitation not only improves the walk distance or any other pulmonary parameters. In our study, we have seen that we assess with this Hamilton's anxiety and depression scales. Their psychological parameters and even fatigue scale also have been improved with this relaxation technique and other pulmonary rehabilitation. So it will be a good technique for most of the long COVID symptoms, what we are seeing usually. Not really all the neurological aspects, but some of the psychological fatigue and always pulmonary manifestation may be benefited.
Thank you, Akhilesh. Dr. Ramya, would you like to add anything?
No, I think we sort of, sorry, Ramya, you want to say something?
Nothing specific, sir. Like I agree with Dr. Akhilesh, sir. Like I mean, a lot of times deep breathing techniques and some form of relaxation therapy, they themselves provide some kind of relief, but not in all cases. Since I mean, still there would be a majority where some pharmacological measures and repeated counseling sessions, reassurance, cutting down on social media exposure, all of it plays a very important role in a holistic recovery. So I think a multi-pronged approach for a case would what might benefit them the most. Yeah.
So, Dr. Ramasubramanian, Ilango wanted to ask a few questions, but he had to leave. So, what are the, I mean, I mean it in the best possible way. So, what are the good things that happened because of COVID?
The good things which happened is, I think, the best thing which I would think of is there was a strong cooperation between various countries in coming up with interventions associated with research. There was sharing of knowledge. So within a month of the virus the epidemic having been identified, people were able to identify the virus, create the genetic material for the virus, and share the knowledge for coming out with the vaccine. So there was a phenomenal international cooperation and collaboration. Sharing of information was in unprecedented scale compared to anything before. And there was a lot of camaraderie in sharing, like India gave vaccines for so many countries. So there was a lot of sharing and, humaneness was visible in most situations during COVID. That would be the best thing I would say. People cooperated.
What are the key lessons? What are the key lessons that COVID has taught us?
Key lessons: it has happened, it can happen again. So we should be wary. COVID was, I would say, mild. If we are hit by something like Ebola with the scale of COVID, I think we are all dead meat.
Dr. Ramya, how do you think medical practice has changed uh, because of COVID? As some changes that have come to stay.
Um, from the medical practice, lot of online consultations and teleconsultations. So basically, especially as a psychiatrist, we were doing only online for a lot of time, and still it continues. People like keep doing the teleconsult, and the medical practice as such, because of the thanks to Google, they have now made it a habit. So whatever medicine, even if we write dose 650, somebody is going to again Google and seek some other reassurance, doctor shopping. So all that has tremendously increased during the time of COVID, because despite certified specialists assuring them or reassuring them and treating them the right way, there were repeated queries to all the doctors. So somebody would see Ram sir, then come to see me for health anxiety. Still they will say take the entire prescription and ask, why was this prescribed? Why was that prescribed and everything? So I think a lot of overlap was there, and it was more of liaising between multidisciplinary teams and sharing our knowledge and insights, as Dr. Akhilesh rightly mentioned. So this kind of collaboration evolved tremendously during the COVID time.
Thank you, Ramya. Radha, you have your hand up. You wanted to say something?
Yes, Vidya, thanks to COVID, we have this marvelous medicine series. And I think it's connected a lot of... Can you hear me?
Yes.
Yes. Thanks to COVID, Dr. Ram, first of all, excellent review. It was wonderful. I'm in the US. I'm off today, so I was able to log in. Usually Vidya keeps sending me these, but I am knee deep in my cases because it's between 9:30 and 11:30 in the morning. So it's just completely impossible for me to get online. Sometimes I do, and then I have to get up. But today I'm at home, so I was able to get on. It was an excellent review, excellent presentation. And I agree with you on all the points that you said. And as far as what COVID has done, few good things I can mention this marvelous medicine series. And thank you, Vidya, for that. And I think it's opened our eyes to a lot of topics that we would otherwise not be looking into. And the other thing is it has also made my 80-plus-year-old mom tech savvy, because now she has to get on Zoom to her Tirupuhar class. Otherwise, she won't be, because she can't go in person. So that's another great thing. I think it's made a lot of people tech savvy. And on the same token, I do understand that it's making a lot of people too much technology dependent. And communication has improved in so many ways, but communication has also come down because of COVID. And great things have happened, I think, but it's sad that it had to happen this way. As you said, it brought a lot of countries together, it brought a lot of people together. And there are still disparities, I think, when as far as COVID, when the disease hit, but still it has brought a lot of people together. Thank you so much for this great presentation. Thanks, Vidya.
All right, thank you, Radha. Radha Krishna, would you like to say something?
No, I'm very disappointed, Vidya, with Ramasubbu's lecture. I expected him to say that the COVID is done and dusted, and latest edition of Harrison will not have COVID anymore. But contrary to that, this is like deja vu to me, as if I was listening to COVID update during the peak of COVID, when all the IT people are very busy moving from one channel to another and, giving up the updates. I mean, that's what I should say. Everything looks still fresh. He's come with what is the latest vaccine schedule, what are the latest medications, and so on and so forth. It looks as though COVID is very much there and is come to stay. It's an excellent lecture, of course. And the last point I want to make here is, I do not know why, but Ramasubbu is voted year after year by the nurses as the most handsome man in Apollo and a more well-dressed gentleman. then I understood that it's not the hair that matters, it's the brain that matters. It's a great talk and a great evening, Ram. Thanks for coming.
Yeah, Puneet, would you like to say something?
And nothing much. I think one question was about the vaccine, whether mixing vaccines, there was some soft evidence that if we switch vaccines, particularly in boosters, there might be, we really don't have that much data. Whatever is there, so circumstantial and so politically driven. Till the UK data came out, I was very suspicious of the vaccine data as well. But, there is some soft data on the mixing. So probably each of these vaccines are acting on a different part of the immune system. And whether, having a natural infection like Omicron does give at least as good immunity, we don't know that. Why haven't we sort of compared vaccines versus actual Omicron? That's the one question. As far as the advantages, benefits, I think for me, it was the other way around from what Ramya said, that I think people started valuing the personal contact much more after COVID, because, for once, Radha knows we've spearheaded webinars before COVID. And we always said, we should not be pharma dependent. And I've come 180 degrees. I don't want death by webinar anymore. Having so much of webinaritis, I crave the personal touch in the conferences, and I'm ready to spend money from my own pocket and go there now. So I think that it did bring out the value of humanity as well. And Ram, as always, a pleasure to listen to you. And like Radha said, if you remember, I always told you that you've been voted year after year, even outside Apollo, as the most handsome bald guy ever. I don't know if you remember that.
Yeah, regarding the vaccine question, yes, conventional wisdom tells us that mixing vaccines from different platforms will give a better response. But you catch Pfizer, saying that you take 1 dose of Pfizer and 1 dose of Covishield. No. So I don't think it is practical.
So why not the government? For instance, I have not taken the booster. I took the original 2. And after this data, I'm waiting to, switch. But they say, whatever you've taken first, you have to take that. So the government isn't it up to you guys to push the government as well? All of us, I mean.
That's for practical considerations, that if, 800 million have taken Covishield and another 200 million have taken Covaxin, because of logistics, it makes sense to give the 800 million the same vaccine rather than try to make Covaxin the second dose.
At least 200 plus 200 will get the opposite one. So why not at least the half the population give them? And we have a fantastic control as well to see and push for different vaccine, isn't it?
See, we still don't have a correct correlate for vaccine protectiveness. This antibody level which we look at is probably one of the... We still cannot quantify T cell response, how it helps. That's why we know that even if the antibody titer is not adequate, still the vaccines are protective. So for various inadequacies, we don't have a good system whereby we can quantify the response for vaccines. Unlike antibody titer for hepatitis B, you say more than 10, it is protective. We still don't have that correlates for COVID.
I just want to mention one quick thing when he talked about, vaccine switching. So when Pfizer came first in the US, so I stood in line on the first day when it was given in our hospital. And at the time, Moderna was not approved. So I took Pfizer, and then by the time I was due for the second dose of Pfizer, Moderna was approved. So several other folks in my department took Moderna. But then I went ahead and took the second dose of Pfizer. And then when the boosters came, I took Pfizer again. And so I have taken the first two original doses and then 3 boosters so far. Whenever any booster was recommended, I went ahead and took it. Because some of the boosters are recommended for over 50. So I was in line again. And so this is my personal experience. So in 2021, right before the third booster, like late 22, before the third booster was approved, there was a small study from Israel or Italy, I don't remember what. So there was a discussion in our lounge about how whoever took Pfizer, probably Moderna is better. So I had taken 2 boosters of Pfizer, and then I switched to Moderna. Boy, my body told me that, okay, I'm seeing something new. And I had to call in sick for 2 days. it really put me down. I had low-grade fever, severe body ache, malaise, as if somebody just beat me up. But I never had that much of side effects with Pfizer, except for exactly, it was like on the clock, 12 hours of fatigue and body ache and malaise, and then I got better, but I still continued to work. I was like tired at work, but still I continued to work. So, but Moderna hit me hard. But my mom and my husband took Moderna, and because probably they took it right from the first time, they didn't have any issues at all. I mean, just some arm ache and some fatigue, but nothing big. So I think when you switch it, probably, I don't know if it gives you more immunity, but your body does tell you that it's a different animal. Thank you.
Any scientific explanation for that, Dr. Ramsu?
No, no. It doesn't mean that if you have a severe reaction, you will respond better immunologically. Nothing proven.
Srividya, you have your hand up. Srividya?
You're muted, Dr. Srividya. No.
Hi, hello. I have unmute. So good talk, Ram. I mean, usually Vidya has to literally drag me to these sessions, but when I saw your name, of course, so I'm there. Excellent talk, and I think really simplified and clarified it very nicely. I mean, always these questions come up about how many days of quarantine, they are asymptomatic and all those things. Really thank you. My just 2 bit about the vaccination mixing. When we started vaccination in India, and I think we have done a huge chunk in Tamil Nadu itself, there was a lot of mixing because patients were just going ahead and taking whatever was available. Sometimes it was inadvertent that, I had one camp at one of the corporates where one elderly patient first went into one tent, and then she didn't realize she went into the other tent. So she got both Covishield and Covaxin on the same day. But nothing happened. And we don't know. We don't know what is going to be the long-term effect. What we did see, which I really want to know, is that after the 2 doses of vaccine, whether it was Covishield or Covaxin, I'm not really sure, there was a huge spate of increase in viral infection or like dengue fever, and very young adults with dengue fever who usually do not get affected that badly were admitted with very low platelet count, significant viral prodrome, and they were quite sick. I mean, with elevated liver enzyme, and all. It took them nearly 10 to 15 days to settle down after, 3 weeks almost, which was not very common. I mean, we usually say the dengue is either in very young or in very old, but we did see a huge, but which kind of, I think PGI did a study on this, and they refused to take the 3rd booster, doctors themselves. So what's your opinion on that?
Humans will be humans.
Well, yeah, that's it. Okay. You mean to say there was no connection, Ram? Because very uncannily, I don't know whether you yourself saw an increased number of dengue after when the COVID started waning. We had a huge, I've never seen this type of increased dengue admission in young adults.
I don't remember a correlation between that. No.
Okay. I don't know. Post-vaccination, is there anything which is like increasing the viremias, or I don't know, but well, maybe something to ponder about, because if I remember PGI did a study about it. I don't think they had any conclusion, but we're suddenly seeing a spate of lot of weird viral illnesses coming up all over after the COVID. Okay.
I think people, just my 2 cents, I think people tend to seek medical attention more for viral illnesses now after COVID. And now again, of course, we've gone the other way. Now we just, everyone started ignoring everything. How does it matter whether it's COVID or flu or some other virus? You just, if you're unwell, take rest, and then you're back in business. So Ramasubramanian, you did mention that no vaccines are available now suddenly in India. What do you think the reason, and what happens from now?
I don't know. I think basically the vaccine stocks ran out and the government did take enough steps and, they started diverting funds to other vaccines. I don't know. But when there is another, new wave which comes in, then people will again come back to it. The new mRNA vaccine which has come, let's hope that it'll come out, because the whole thing is still under the government's hand. Very difficult to speculate on what they have been thinking. So I don't know.
So because this is this new vaccine is the only bivalent vaccine that would be available, so your recommendation would be that if and when it becomes available, we should all take it.
At least the vulnerable, the people who have not had boosters or people who have had boosters but still are very vulnerable, yes, I would suggest, yes.
Any closing comments, Ram? We are at 9:30.
No, I think the only comment would be, if it has happened once, it can happen again. So please be wary. Please, take precautions. At least if there is news about any new changes or emerging infections, please be wary. Now the communication is excellent. Two, do not panic. I think one thing I personally realized during the times of COVID was the one most important weapon all of us need to bolster ourselves with is common sense. Common sense is not as common as we think it is. As long as you think sensibly, I think there shouldn't be problem. That's the only advice.
Thank you so much, Ram. And
Vidya, one last thing. I just wanted to mention, this is Radha here again. So with COVID, when people were wearing masks, we saw in the US that the flu incidence was down. But now that people are taking off the masks, apparently the flu is attacking with much more vengeance than before. That's number one. Number two, what I have been hearing from my colleagues and other folks with young kids, because kids, younger kids like 2 and 3 year olds are needing speech therapy now, because they're not seeing, apparently the speech therapists are telling those parents, my colleagues who are parents, young parents, that kids learn a lot from visual cues, from seeing people's mouths moving, because they're not seeing that because of the masking. Kids are having more and more issues with talking and using the right mouth movement for different different phonetics and syllables and stuff. So more and more kids are apparently going for speech therapy now in the US. I don't know what the situation is in India. Just to be aware.
Yeah, I think it is intuitive that does happen. The children, if Ramya is still there, maybe she can comment. Yes, wearing a mask will prevent visual cues, and children may have difficulty with speech.
Yes, sir. As we mentioned, social skills, one important skill for children is to understand not only the just lip movement, but the body language and all that. So masks always being there. I have seen a lot of people with dementia having poor face recognition, because they can't apprehend, they can't understand what is happening when somebody is speaking with a mask on. So for both children and also people with moderate to severe dementia, this mask and their ability to associate or socialize with somebody is a problem, and social skill deficits are there. It's a real-time problem. Yeah.
Thank you, Ramya. Thank you, everyone, for making this session so interactive. Thank you once again, Ram, for agreeing to do this session and giving your trademark talk with so many take-home points. We'll meet again next week with an episode of Beyond Medicine. We are going to have 4 doctors who are writing, who are authors and who have published other than medical literature. We invite you to join us for the next week's session and for future sessions of Marvelous Medicine. Till we meet again next week, please take care and stay safe. Good night.
Thank you, Dr. Vidya. Thank you, Dr. Akhilesh and Ramya. Bye-bye.
Thank you, sir. Thank you. Thank you all. Thank you.